is low or something like that because of the network, right? So these are the topics we are going to discuss. We'll look at service delivery indicators, data sources. We'll look at performance indicators and what criteria do we use to select performance indicators. And how do we apply and report performance measures? And what mechanism do we use in collecting data and aggregating them for the purpose of monitoring and evaluation? And we also look at some important aspects. We all know how important data is. So we look at the policies and the regulations that are common for data protection. And we can now see how health information system will be integrated or how rehabilitation will be integrated in health information system. We shall also look at engaging rehabilitation users. You know, definitely the service users have to be engaged as well. And how do we keep the records properly and how do we analyze data, especially using standardized outcome measures and surveys. And from there, we can conclude with a few remarks and we give floor for question and answers. And from there, we'll look at case studies. And I think these case studies are the most important or key aspects actually, because we'll look at how monitoring and evaluation are conducted across the globe and in sub-Saharan Africa and somewhere within Nigeria. Now, by way of introduction, we all know when we talk about monitoring, is an activity to have watch and have close observation regarding what an organization is doing or what, and in fact, we can remember during our secondary school days, we used to have monitors in classes. So it is the same thing, is a term that is global, so it applies in specific things. And for all successful establishments, monitoring and evaluation unit and activities are very, very key, because it is when we monitor, we can see all parameters are properly implemented. And in the aspect of implementation, where there are issues, we can now retrieve and come back and look at where the issues are and correct and put forth for the purpose of the success of the establishment and giving value for money for the services that may be rendered to the benefactors. Now, when we talk about it briefly, first of all, we are talking, like I've said, is about service delivery. It is successes and promising what it is supposed to be. So for that, we have to identify what are these indicators of these service deliveries, right? So basically, there are key indicators, especially in our own context. There are majorly 3 or 4, right? One of it is accessibility. When we talk about accessibility, what are we actually referring to? Is how the rehabilitation services are accessible to those end users of the services, right? What are things that determine the accessibility of the services that are delivered? Some of them include the appointment availability. Of course, for a client to access your services, he must at least get an appointment. So how well, how efficient we prepare or organize our appointments and make them available for our benefactors now or beneficiaries. And then another point for accessibility is the issue of waiting time. If our client will come to access our services, how much will they spend? How much time will they spend? Of course, time is everything. If there are 2 or 3 different service providers, when you go to service provider A, you spend as much as 30 minutes for you to get what you want and leave. Now, service provider B will give you the same services of sort, but you may stay for about an hour or so. And maybe service provider C will give you the same services, but for in the next 2 or 3 hours. Or you are not sure actually, you may not even be sure. You just go there and be waiting. Your guess is as good as mine. I'm very, very sure we are going to patronize service provider A. So these indicators are very, very important, right? And another area is the location, your geographic reach for the services is also very, very key to determine the accessibility. You may look at the smallest geographical aspect. For instance, if you have proper service, parking area for persons that will come with their vehicle, or maybe when people go to your service facility, you know, go maybe spend about 2 or 3 hours. Unfortunately, or otherwise, the road is not uh, conveniently accessible. You will believe with me that the services, the accessibility will be affected, and definitely the client may not want to subject themselves to that. Now, another aspect is how effective is our services. One of these key aspects that we look at in effectiveness is patient's progress. Of course, for every client to come to us with a concern, his belief is once he get there, he receive the services we deliver, he should progress and get better and go back to his, what do you call it, normal day-to-day activities, right? So this one will determine how our service delivery will be effective. Another point is the treatment adherence. Our approach to make sure that our clients adhere to the treatment is very, very efficient. I have an experience somewhere during my practice. What I observe is if you give client a home program, for instance, when he comes back to your facility and you ask him after normal greetings, how was your day? How was your home program? Have you been doing it? The answer will always be yes. But however, if you ask them to demonstrate exactly what you ask them to do, you will see signs of either lack of adherence or some key aspects are missing. So for us to ensure that the adherence are there, we have some indicators that we look at. For instance, asking the client, how effective does he do what you asked him to do? So with that, it will make client to make sure that he uh, adhere to improvement. All these ones determines or describe the effectiveness of the services, right? And others include achievement of the goals that we set. Now, the other key indicator is efficiency. Now, when we talk about efficiency, is referring to how well we utilize our available resources, right? What we give our client as our services, for instance, if we give them sessions per time, and how does it relate with the costs? How does it relate with the cost, and how does it also relate with the outcome of the services we render? And another important aspect is the issue of safety, right? For every aspect, for every services we give, the issue of client safety as well as the professional safety and even the people around is very, very key, because this is where we look at the incidences of adverse events that may have occurred, and how much so once in a while we assess those things and see how regular or how frequent they occur and what action is taken. Another one is perhaps infection rates in our area. So how well do we disinfect area to make sure that infections are not rampant, and also issues, especially around context related with our equipment. How well, how safe are equipments, how safe are they with the services we render? So these are majorly the key indicators that are expected to identify in our services delivery. Now, for the data requirement for keeping some of these things, basically not all, we look at the demographic data of our clients, right, that we deliver our services for. And this will help us know what services are demanded from us. For instance, if in your demography generally, you discover that mostly the clients that attend the clinic are pediatrics or mostly are elderly patients, definitely this one will determine what best we have to provide for the clients to benefit. Another issue is the gender, their socio-economic status. This will all help us to assess the impact of our services on varying population that we deal with. Now, the clinical data includes our diagnosis, how able we are able to have the diagnosis, and what diagnoses appear frequently and more regular, right? And the details of the sessions that our client have, and the treatment type they receive, and as well as possibly the outcome that, what do you call it? The outcome measures and the records. All these things, if we can be monitoring them and evaluating them, it will help us in efficiently delivering our services. Now, all these things are data that we need to look at. Now, another one is the operational data, right? Which will, we will generally look at our staff information regarding our staffing, availability of the necessary or needed resources, and details of the facilities are all what it is expected to be captured in our operational data. Now, the sources of all these data are from where usually? Mostly are from electronic records that we keep. So they are retrieved and assessed and analyzed, and all this information we bring out from the raw data to give us a meaningful information. So another one is we can be throwing out surveys to get subjective information that will give us some ideas regarding the indicators of our efficiency and effectiveness in service delivery. It also suffices if we can be looking at, what do you call it, the satisfaction of our clients, as well as their perceived improvement of their conditions, right? And the facility data system, like I mentioned earlier, the facility data covers the issue of the staffing, the scheduling of our visits, and how we utilize our equipment and how we keep and maintain them effectively. The next aspect after the key indicators is the performance indicators as well. So this, the earlier one that we discussed is talking about the general aspects of this. Now it is getting to specifics. How do we assess our performance, right? And how we need to have that will give the performance of the facility and that are mounting them. So usually the potential indicators that we have mostly are the patient outcomes, the patient experience, the operational efficiencies, as well as the safety. So you can see they are basically the same thing, but there is the approach to what we want to get out of them. For instance, in our patient outcome, what we look at is the rate of recovery of clients as they come in. How long do they stay in our facility before they recover? Or how well do they improve functionally, and eventually how much or how fast or how able they were returned to their work. All these matrices we assess to give us the potential indicators for our service performance. Now, if we look at all these ones, there is other aspect of patients' experiences. This one we extract from our clients, whether we call them, I would interchangeably patient and clients, but I'm referring to the same service beneficiaries that we'll be talking about. Now, patient experience is also very, very important because that is when it will give us idea of our service delivery. For instance, we look at the patient satisfaction scores. We look at the waiting time. We look at the accessibility of information. All these one are vital information that we extract from our patients to determine how, what their experience look like with the facility. It will help us in improving our services because they are the ones that will determine the rate of our performance. Now, the other point is the operational efficiency. How efficient is our operations in running the service facility? For instance, we look at the treatment duration, how long does it cost our client, and how do we allocate the available resources very well so that we cater for, you remember we talked about the waiting time, accessibility, and then we try to compare and look and see how we can slot it all these ones to make sure that the patient satisfaction is attained. Again, the other aspect is the safety. In this aspect, we look at the rate of adverse incidents that have occurred, either from patient complaints or from our records and so on and so forth. So all these things will give us performance indicators. Now, how do we consider these performance indicators when we come to select? We make sure we are able to identify and sort them out based on their relevance to our organizational goals, right? So mostly the indicators, as explained earlier, are chosen to make sure that they align with the goals of our organization as well as our patients' needs. When we get to the last aspect of our presentation where we discuss the case studies, all these things will be seen very, very clearly. Now, the other aspect is the measurability. So whatever indicator we are going to choose or select, we have to make sure that they are measurable, meaning we can be able to collect a reasonable data that will give us vital information for comparison with other available resources. Then comparability again. Once we measure, we are able to collect reliable data, and yes, we can now be able to compare them with some other standardized indicators. This one will give us clear comparison of services across facilities and with time or over time. Now, the other point is, like we said, is actionability, right? So basically what they are referring to is that indicators should be able to provide an actionable insights so that it will give us way to see how we can improve from our existing available services. The important thing is mostly is to, what do you call it? Improve on what we have as our existing protocols based on the experiences and information we gathered from our clients. Remember, basically, almost all these things rallies around our clients because their satisfaction is key so that they get value for the services they receive. Now, the other aspect is implementation. And you remember, like I said, mostly when we talk about monitoring and evaluation, it's about looking and assessing implementation of all our policies and goals and guidelines and regulations in our service domains. So usually we look at the implementation efficiency effective via regular tracking and assessing, as well as benchmarking from available existing or standardized indicators, as well as analyzing all what we have so that it will help us in pushing our services to a better height. Now, the next one is, how do we now apply these performance measures and how do we now report them? Very, very important, right? So when we are talking about the application, how do we apply it? Just like we have mentioned earlier, is about implementation, right? We should always strive to regularly track performance indicators. This will help us establish baseline performance, and we can easily monitor changes as time goes on. Now, the interpretation is very, very important for us to be able to report properly, right? How do we do the interpretation? We interpret the indicators by comparing the available data against either benchmark or some data that are there or industrial standards. For instance, we are in the health industry, so we should be able to have the standards of the health industry. And then once we have our own, what do you call it, information, we look at how we can interpret and compare available data we have raised with the industrial standards. Another aspect of interpretation is to be able to analyze the trends from the existing data so as we'll be able to identify where we have strengths and where we need to improve. Very, very vital. Because in every aspect, you can be able to identify where you are strong and where you have some lacking and require some improvements. Now, the other one is we compare available information for our outcome from before to after, like just pre and post intervention outcomes comparison, so that we can see the successes or otherwise of our interventions. And then based on that, it will help us to understand the impact of our services and where there is need for improvement. As such, we'll be able to do so. Now for reporting, it's very, very clear for every information that we have. If we keep it under lock and key, it is as good as useless, right? So what is done is to prepare from the existing information that we got, we interpret and we compare. We cannot develop a report, right? So that the various stakeholders will be fed with the information. It can be in the form of dashboard, which is usually given for administrators. You know, they always prepare something that comes in summary, right? So that they don't have to spend much time. And then it can be in clear, detailed information, maybe like a case studies, so that it will be presented and shared for the purpose of our clinical staff, and so on and so forth. So we identify the key stakeholders, including our clients. They are also major key stakeholders, right? And now when we are reporting, it is ideal and more advisable so that the information will be getting clearly and what do you call it? absorb comprehensively, if we can be using infographics such as, what do you call it, charts, and so on and so on, because this one will help in translating and giving the information more clearly to the consumers for better comprehension. We can also use tables and other things. We can even use animations for that. And in whatever we are doing, when it comes to the issue of reporting, transparency is very, very important, especially where the issue of disclosure are warranted. We have to, although there are issues of data protection, but we disclose where it matters most. And where there are limitations, we also have it clearly, what do you call it, express it out. And the important thing is to see how well our facility is performing so that our clients, as rehabilitation experts, benefit and get the best of our services. So mostly where the emphasis is where we can identify areas that needs further improvement. Right? Now the other aspect is, hello?
We are with you, sir. We can hear you, sir.
All right. All right. Now another important aspect of what evaluation and rehabilitation services is how do we collect the data and aggregate them? Very, very important and very, very vital to look at. So usually in this aspect, we will look at basically the tools that are required for the collection of data and the methods that are used to aggregate as well as integrate the data. Now for the tools, we have various tools abound for data collection. For instance, electronic health records, all we need is to go and retrieve them because it is automatically captured there and it has detailed information that covers the basic and vital patient as well as treatment details. So we can access the data and collect them from our health records. And sometimes, especially in this era, we use mobile applications where we give it easy for the patients to report their information like the symptoms and satisfaction after their treatment and so on and so forth. Another one is via use of manual surveys, right? Developing questionnaires or maybe using the available ones, the existing ones, so that we can share them, right? For gathering information. Now, the aggregation. How do we aggregate data? Now, when we talk about the issue of aggregation, is more or less like how can we have our data well safe and well kept in a proper and more formal way. So usually it uses centralized databases so that the information will be compiled from various sources. And at the end, we should easily access them for our own consumption, for analysis and bringing out what we need from them. That is what is called data warehouse. Then the other one is standardizing the data. This is the data standardization, meaning that the data that is collected is make sure that it's standardized and it makes sure there are sources of errors in the data as much as possible eliminated, reduced or avoided if possible. Otherwise, it should be reduced as much as possible. And this will help, as standardization help us make sure that there are consistency with data across sources and within sources. And the data is expected to be consistent and well qualitative, right? Now, how do we integrate? Okay, also part of the aggregation, there is need for regular or periodic auditing of the data. The data should be assessed and audited regularly so that the accuracy will be consistently and continuously verified, and we make sure the data is complete, right? Now, when we talk about the integration, same thing, bringing the data as centrally compiled so that from various aspects are brought together and analyzed so that we can have easier access to them. Now, another part is the issue of the policy, right? The data, of course, you remember I mentioned earlier the issue of data protection. You know, data is a very, very sensitive information. Nowadays, even countries are using data or information about against other countries. So the same thing, the data protection is very, very important, right? So basically, we look at the privacy and confidentiality of the data. We look at how do we control access data and how do we make sure that we follow and stick to standardized reporting procedures. Now, for privacy, usually it is always encouraging adhere to data protection regulations that we have them all over. In Nigeria, we have the National Data Protection Regulation Policy. So it clearly spelled out how data are utilized and how confidentiality and privacy generally are protected. In our own context, we all know part of our professional calling is to make sure that clients' information is kept confidential and private, except where the need arises. Now, data is also secured in a store and it is always anonymized, especially the sensitive information of the clients are kept anonymous as much as possible, right? And access control too, which is another important aspect of data protection policy. There must be diligent implementation of access control policies. This will help us limit data access to unauthorized persons. So it means it's only authorized persons that will be allowed access the data. And the same thing, if we can ensure that, we should also make sure that there are continuous review of the access privileges, right? So that people may not be misusing the privileges given to them for the access of the data, especially when they see there is no review or monitoring of their access, the data. Now, the aspect of reporting standards. There are generally established guidelines for data reporting, right? In our own case, mostly we have the World Health Organization framework for health services performance reporting, which is clearly spelling out how do we report data, including patients, conditions, their consent, and so on and so forth. Now, another one is complying with the formats that are consistent and using the units that are standardized reporting for various rehabilitation services. Again, like I said, we can get this clearer information when we go to our case studies. I don't know the anchor. How do we plan it? Do we have break time, and what time do we have so that I can plan? Mrs. Tolu? Hello? Hello? Are we together, Mrs. Tolu? Why is my co-host?
Yes, sir.
Yeah, so I wanted to ask, how do we agree? When do we have break so that I can see how I break the work? Maybe I'll try to finish the presentation, and then maybe when we come back, we may listen to questions and answers and discussions, and then we go on break, and then when we come back, we just concentrate on the case studies, because I try to bring an idea of all these various subtopics as they are implemented in various health facilities across some global regions and even Africa. So I think we'll try to finish the first part and then we'll go on break. But I want us to agree what time is the break and how long we stay for the break.
Sir, the break is dependent on the things we have to cover, sir. So if we have a lot to cover, we may not really have that much time for so much breaks.
Okay.
That's it, sir.
So maybe let's agree and have the break around 12, 12:30.
Okay. Okay, sir.
Maybe we can have just 15 break.
Okay, sir.
And we can come and continue.
All right, sir.
All right, thank you. Yeah.
Yes, sir.
Now, the other important aspect of data, monitoring and evaluation is the use of what? Health information system. How do we integrate them? Very, very important for our rehabilitation services, right? Now, first, we need to understand the structure of the HIM before, HIS before we can think of how to go by integrating it, right? So usually, typically the health information system provides modules for patient registration, right? Their medical records, their billing, as well as rehab reporting. So these are the basically four key modules that make up the health information system structurally. So patient registration is when the patient come in, he get all his information and all is required, including what area of the services he is going, if it is general outpatient, if it is if it is a specialty clinic, and so on and so on. So this one is captured in the patient info, general patient registration. Sorry, the patient registration is talking about the data of the patient, the biodata of the patient, which includes his gender, age, what do you call it, socioeconomic status, address, something, and so on and so forth, right? Then the other aspect is the medical record. This one is where all the information regarding the medical history of the clients, initially and subsequently, they are covered under the medical records. And then the other one is the billing aspect. The billing aspect is telling us the charges patient pays for the services rendered, whether it is via NHIA or it is retainership or it is direct and so on and so forth. And then the reporting aspect, right? So in this one, we understand this. And now we can look at, for a rehabilitation one, we expect these key areas to cover some of these places like this. The specific data, like we say, after the, what do you call it, the patient registration, the medical records, right? It should cover areas of, what do you call it, treatment plans, functional progress, follow-up, management, as well as outcome. All these ones should now be integrated into this structure, or are integrated where they are into the structure. I mean, into the, yes, the medical health information structure. Now the integration here, like we mean, is to share the information between the rehabilitation as well as the general patient's records, right? This one will help us to come up with a holistic approach to the patient or to the client management. This is one of the benefits of the data sharing, right? And then the other one is the interoperability of the system, meaning that the health information system is ensured that it is operated within and with other systems, so that it will enable seamless data information exchange across, either we call it department, facilities, unit, services, and so on and so forth. It is very, very key in in assessing, I mean, or ensuring proper evaluation of rehabilitation services. Now, another aspect is, for a successful rehabilitation evaluation and monitoring, the service, the service users must be kept engaged as well. This is where we can get some vital, or maybe what can I say, some salient informations, right? So how do we engage them? We engage them using coming up with surveys, right? This one will help us: surveys, focus group discussion, follow-up calls. All this one will help us in, what do you call, receiving or getting feedback from the patients, right? Usually for surveys, we all know we use structures or structured questionnaire so that we can gather some information in the form of feedback on whether it is satisfaction, accessibility, overall experience, and so on and so forth. We can also have a focus group interaction as part of the feedback mechanism, so that we can have a given group to sit together and discuss, so that we can get deeper information and insight regarding their experiences with our service delivery. And follow-up calls, this is about personalized communication, get information directly from your client, especially for the issue of long-term outcomes. And it will help get information that may require some concerns that need to be addressed, right? Now, this engagement has benefits such as helping us incorporating clients' feedback in our services, which will guide us in improving our quality of services. It will also give us ability to enhance our service delivery. And another important advantage or the benefit is giving patients more trust and confidence about our services.
Sir, I can't hear you. I don't know if it's general. Probably the audio
Hello?
is okay. We can hear you now,
Hello?
sir.
Okay, I
Can
think
now
it's the
hear.
network that just
Okay,
shook from my side. I was
all right, sir.
almost gone. Yeah.
Thank you, sir.
Yeah, so another aspect, are we together? Yeah, is the area of record keeping as well as data analysis. They are another important or vital aspects of monitoring and evaluation actually. Now, the best practice is, is to maintain properly organized, up-to-date, and accurate records for each client. And the records are expected to be covered by category. For instance, we can have, just like we mentioned, the various structure of the health information system. We should have our clinical notes clearly specified or separated, our billing information separate, treatment outcomes separate, so that when we need to refer to them, it can be easily utilized than if they are all jam-packed for you to be extracting what you needed. Specifically, it will be very inconvenient. The other one is record keeping using digital means, right? Because using the digital approach to keep records, it helps us in having access to data, right, more easily across and between services and facilities. And it a lot reduces chances of data loss or the risks of loss of data. Now, when we talk about the issue of data analysis, sorry for the record keeping, part of it is the issue of the audit of the services, right? In that aspect, usually the policies include defining the scope as well as the objectives of of the audit, as well as criteria that can be adopted for the auditing service, and the frequency with which the auditing is done on the given facility, which is usually dependent on the facility's needs, right? And the procedures, usually we need to have a structured approach so that it involves just the results in data collection, record review, then interviewing staff, and then from there, we should be able to identify where non-compliant issues are there. Maybe we can also track issue of where we need to correct actions, whether they are corrected or not, and follow up too, so that we make sure that all that is put in place is being implemented so that improvements will be seen and recorded properly. Now, the issue of analysis, usually we use statistical methods. Depending on the data we have, if it is a simple survey, we need the simple descriptive statistics so that we can be able to identify a lot of information regarding the trends, access as well as service quality, performance, where there are a lot of information we can be using like I said, various approaches, right? so that we can be able to analyze and come up with clearer picture of um, what actually is going on with the facility. Now, the other aspect is the visualization of the data. Like I mentioned earlier, when you have the data as an information, after analysis, you provide it in a clearer way when it can give more understandable, unambiguous information. And the common way to do that is providing them in what? In charts, in dashboards, and so on and so forth, where we can see the trends, we can see the comparison, we can see the proportions, and so on and so forth, right? Dashboards, like we said, it gives especially the administrators, ability to monitor. I maybe this place, I try to give example of this dashboard. Um, there is this issue that happened in one of these states. When I think the governor visited the general hospital. One clear thing that came out was that basically the toilet facilities are very, very poor, as if they are not being taken care of. So he now called the commissioner for health and gave him, I think, a week or so that he wants to come up with something that he doesn't want to see, he doesn't want to hear all this. This one is what he saw. But he said that because he had some complaints about that, that's why when he went for the tower, he specifically looked for that. So what they did was to come up with an analysis identifying all the hospitals, and each hospital they identified the total number of toilets and the number of facilities within the toilet. All these ones are just presented in dashboards. So they now color them, the number of hospitals, for instance, in green, the number of toilets per hospital, column by rows in red, and so on. So they put all the information, and they now mention that there will be a soft copy that an information will be coming from various facilities. Today, this toilet is clean by so person. So these are what the dashboard is talking about. The summary of the clearer picture of everything, and from there, the stakeholder, especially the administration, will be able to see, and they get proper guide on where to address what. Now, standardized outcome measures and surveys that are usually used for our record. Usually, when we talk about the standardized tool, we are talking about tools that whose psychometric properties are clearly satisfied. Their validity, their reliability, their utility, their sensitivity, their specificity, and so on and so forth, right? For instance, one of the common tools that we have is the FIM, Functional Independence Measure, or PSFS, Patient Specific Functional Scale. So these are some of the standardized tools that can be used so that we can assess our service outcome. This is the general thing. But depending on the condition, so there are 101 tools. So, but we make sure that whatever tools we use, it is standardized one, meaning that its validity is tested, its psychometric properties have no issues, and so on and so forth, right? Now, the advantages of using the standardized tissue is that they will give us clearer information that will permit us have comparison across patients, across facilities. It will help us improve service. It will help us evaluate services because of their reliability. Now the survey designs, whatever one that we intend to do, we make sure it is consistent with the global best practices. So it has to be very, very clear, relevant in terms of the information we want to extract, right? It can be in the form of qualitative study or quantitative study approach. But the important is that it should be very, very clear, and we should have very relevant questions to ask. Yeah, and then so when we have the design, right? For instance, if we want to distribution, there are various approaches to distribute, what do you call it? Our surveys or information. It can be using mixed method, whether we can have the paper, we have the online, or we can have mobile app, and so on and so that we can have bigger or wider patient-based coverage, right? And the surveys will now be analyzed, and the result will give clearer information about the services we have and where this improvement is required, or where the policies should be adjusted to cater for our, what do you call it, our clients. So this is, so far we have so much we have on the vital information regarding this. I want to thank you everybody for listening, and now we can open the floor for discussions, questions and answers before we go and break. And then when we come back, we'll look at the case studies of rehabilitation services. As you can see from this slide, rehabilitation services in sub-Saharan Africa and Nigeria as case studies to address all these important subheadings. Thank you very much.
Thank you very much, sir. Are there questions or contributions? Please kindly raise your virtual hand or you will mute and speak. Thank you very much.
Hello, are there questions? Where is the...
No hand raised yet, sir.
Okay.
Hello, good afternoon, sir.
Yeah, good afternoon.
Yes, thank you very much for the presentation, sir. My name is Bumi Samuel. I practice in Yola, Modibadama University. I was your student in Maiduguri. So,
Oh,
sir,
you are welcome, Buni.
yes, sir.
How are you?
I'm doing fine, sir. Thank you.
Oh.
So, sir, my question is concerning technology used in documentation. Are there any systems or applications for these documentations that are most popular that can be used for documentation, especially since we're advancing towards technology? And is there? Yes, currently in Yola we use an EHR record system. It's just a sheet that has consultation, diagnosis, prescription plan, and all that. So are there anything, maybe something new that we could know about, and how far technology is or concerning documenting and in physiotherapy?
Okay, thank you.
Yes.
Not that I know actually, but maybe people will add some contribution of that. But generally, these health information records that we have are basically applications that are developed. So usually there are hospital specific, or each hospital will come over, we identify their consultant to develop their own. But basically what is expected is all the service providers should be should be sought. For instance, the hospital where you have physiotherapy services, medical
so what I'm trying to tell you is that
so the physiotherapy services, when the information system is to be developed, the physiotherapy department is supposed to be involved so that they will be the ones that will give the basic information that is expected of their clients and their services, so that it is imputed into it. I think the general issues, as I observed from the few areas that I went, mostly when they are developing the application, they don't really carry the departments along. Because I was in one of the hospitals. The hospital is covered with electronic health information services, health record, but physiotherapy department. So I think basically these are the issues that we have around. And maybe that's why this part of the lectures we are having, it can give us the idea, and we can now go, if we are employers, if we are employed, we can go and raise some of these things and show them what is expected to be covered in our own services. And then if we are employers too, we need to adjust and adapt the current practices. When we come to the case reports, we will see some of them that are used all over the world. Thank you.
Thank you very much, sir. Thank you, sir.
Yes, any other person?
Good morning, sir. There is a question on the chat.
Okay. So yeah, we have a question from Sunday James Arogundade, right? Yeah, the question is there standardized questionnaire for evaluation? One, are there physiotherapy adapted and telerehabilitation enabled dashboards for clients and patients? Thank you very much. For the issue of monitoring and evaluation, it is a global thing. Like I said earlier, when we talk about monitoring, it's just to ensure there are proper implementation of policies or services or whatever of an organization or for an organization, right? So definitely there are a lot of tools that are there standard, but sometimes when you go to access them, you see for your own services, you may need to look one and adapt or to adjust or to modify to fit your, what do you call it, needs. But generally is for you to identify what are the key elements that make up the services that you render. Like I mentioned at the beginning, these key indicators are very, very key. The issue of accessibility, the effectiveness, the efficiency, the safety, and so on and so forth. So evaluation is general. This is in our own context. Maybe when you go to the building industry, their own monitoring and evaluation is different. Are you getting it? Perhaps if you go to Ministry of Works and Housing, their own, and you agree with me, all these, what do you call it, facilities, what do I call it, industries, they have monitoring and evaluation. In the health sector, we also have, there are specific for public health, there are specific for hospitals, there are specific, but now what we are saying, now that we are bringing in rehabilitation integrated in the universal health coverage, we need to look at these key areas so that we can see our services are delivered efficiently and effectively, and our clients get the best benefit of it. So talking about standardized, they are all, like I said, when we got this, you'll be surprised, even as we're talking, there are motor evaluation of rehabilitation in university of hospital. But are we sure we are carried along? That's where the issue is, right? And are we sure what they are doing is in tandem with the global best practice and is as recommended by what? So that's where the question. Now, the other one that you say, are there locality adapted dashboards? Not that I know, but I'm very, very sure, especially maybe some of us here are experts in this issue of telerehabilitation. I'm very, very sure there are 101 of them all over. As like I said, is for us to look at them and see where we may need, what conforms with our own services. You remember that's what we said somewhere in the lecture, that all these things, you have to be specific. You must know what you really need. It's not like one size fits all, but you specify what are the areas and what are the indicators that you may require so that you can use them for developing your own evaluation or mental evaluation tools. Thank you. So like I said, if there is anybody that has something that you will contribute, the floor is open. Just to raise your hand and we give you the floor. No, I mean, so Mrs. Tolu,
Yes,
yeah,
please, sir.
yeah. So in the absence of no more questions, can we declare the break and come
Yes,
back
we can
sometime?
take the break to come back by 12 o'clock, sir.
All right.
Thank you very much.
Thank you.
Please,
All
it's
right.
break time now. We'll return and
Yeah,
assemble back by 12. Thank you very much.
you're welcome.
Yes, sir. It's about 2 minutes past 12 now. Our break is over. So, Prof, sir, you can continue with the workshop, sir. Kindly unmute, sir. You're still muted, sir.
Well done. Can I share my slide now?
Your slide is still on the screen, sir. Yes,
All
sir.
right.
So you just navigate to where you want it, yes, sir.
Okay. Yeah. Is it here? Yeah, so welcome back. We just finished the question and answer aspect. Although I wanted it to be interactive, I thought people will also contribute the little they have. But it's fine. Now we are going to the other aspect. Now, like I said, we are going to the case studies so that we will look at what obtains in other places as regard the monitoring and evaluation of services in various health facilities. In both sub-Saharan and Africa, and possibly if I can remember some examples of other Western countries, the developed countries, maybe we can be able to give example of one or two of them so that we see what they actually do. Now, I want to take it according to the headings that we already discussed. For instance, I think our first heading is, why am I not moving? So for the service delivery indicators, right? Are we together? Are the people back?
Yes, sir, we are together, sir.
All right. Now for the service delivery, we have example of 3 countries in Africa. I think if I remember very well, I tried to distribute them across. For instance, in Botswana, their Ministry of Health implemented a system that tracks data for rehabilitation services, right? What does it do? It monitors the access to treatment. It also records the visit frequency and the recovery outcomes at the end, right? And the purpose is to what? Is to see and help them improve resource allocation to where the demands are high. Like I gave example, for instance, if in my clinic, in my hospital, for instance, I have this system that tracks all these activities, and I now at the end collected the data, analyzed, and discovered that most of these things are better off in, what do you call it, in the area of geriatrics, right? That is telling me that I may have more geriatrics clients trooping into my service facility. So as that, when I come to allocate my little resources, I will make sure I give that area, what do you call it, more allocation, while I try to improve the other areas from where we identify they are lacking, right? So the same thing in another hospital in Ghana, the Kolebu Teaching Hospital. They used demography and clinical indicators. What does it help them do? it helps them track rehabilitation outcomes, which will give them the idea to decide where to adjust their policies so as to improve what the underserved clients. See, so like for instance, it is discovered that some have no, what do you call it, insurance, they don't have, what have you, remind me please, they don't have retainership. In fact, you discover maybe some clients are supposed to come 3 times in a week. However, you see them maybe coming 2 times, missing one of the appointment days. So with this information that you generate, you discover that maybe one of the reasons they are not coming is they have issue with even their money for transportation, isn't it? To come to the facility and back is the taxing. So from there, they will be able to identify the much underserved client and see how they can make sure that the access to their services improve for those population set. So in Ghana also, their National Rehabilitation Center monitors patient satisfaction, their treatment adherence, as well as follow-up visit frequency, which they analyze about every 3 months in a year, just to be able to identify where there are gaps in services. Now, another one is a healthcare facility or an organization in the United States, right? They track their indicators such as patient satisfaction, the length of stay, as well as improvement of functional status of their clients in the rehabilitation services, right? They generated this data they collect through electronic health record system, right? And some of them, they get it from patient-reported outcomes using post-treatment surveys, right? They use that and they keep monitoring these indicators continuously, right? And it helps them to identify areas where they enhance patient care. For instance, adjusting the staff levels, right? Especially when there is a time where they see it as a peak time, where they have more and more clients, right? And sometimes they even personalize some of their patient services like patient education, right? Just for the purpose of seeing that their clients are what? Adhered very well to their interventions. So this is some of the way these monitor evaluation indicators are applied. This one is for the service delivery. Now we shall see for, what is the trouble here? Now we shall see for service delivery indicators in our own country. We have example of about 3 hospitals: the National Hospital Igbobi, the Federal Neuropsychiatric Yaba, and University of Abuja Teaching Hospital. For the National Orthopedic Hospital, they track patient waiting time, service accessibility, as well as functional recovery scores, right? They collected their information using their electronic health record as well, right? And also follow-up surveys. And what they use with this, the important thing is to see how they reduce their clients' waiting time. For neuropsychiatric hospital in Yaba, in their own case, they monitor treatment adherence, of course, relapse rate, as well as recovery outcome, right? They review their data regularly, which subsequently gave them the ability to develop a community-based support program. So you can see how beneficial the monitoring and evaluation, if it is done effectively, and especially with identifying what really matters, at least for the purpose of the facility. For University of Ojo, what they do, they track patient satisfaction, accessibility, as well as time to recovery, meaning time from, admission and management recovery, right? As a result, what does it help them do? It helped them inform the staffing and the management scheduling adjustments. So because you can discover that sometimes you see some hospitals, they have their appointment up until evening. So some clients will be given their appointment from around 4:30 in the evening, while others are coming around 9, 10, others around 12. So all these ones are as a result of looking at the service delivery indicators and identify where they need to do what, right? So the same thing, I have an example of the National Health Service of the United Kingdom that uses a set of standardized performance indicators, such as timely access to care, cost effectiveness, as well as functional recovery after treatment among their strong rehabilitation program, right? So based on that, they now prioritize the indicators that have direct effect on the recovery outcomes, such as time from admission to the start of rehabilitation, right? So in essence, they focus on time-sensitive indicators. You remember at the beginning I mentioned that all these indicators, you identify what you see you may need. You may not carry everything at a time. You can start somewhere. So with time, it can be advanced, it can be improved, and more can be added, so as to serve the clients in the best possible way. So because of what I mentioned, they are able to significantly reduce the delay and enhance recovery rates of their clients. So these are some of the advantages of application of all these, what do you call it, approaches. Now for service performance, there is a center in Australia that is called AROC, Australian Rehabilitation Outcome Center, right? This center purposely does what? It generates or it gathers information and reports them based on rehabilitation data from various facilities across the country, right? And they use specific performance measures such as the FIM that I mentioned earlier, that they use before and after treatment, right? And based on that, they interpret their performance relative to the national benchmark of the various facilities. And with these outcomes, using the national benchmarking reports, this center enables facilities to target specific areas. So you can see it is a center that is established for this purpose, but it can be assisting various facilities in their own areas, right? So one of where they happen is they target some facilities, specific areas for improvement. In fact, as a result, they were able to achieve 5% annual increase in patient independence scores across the facilities that they assessed. So this is service performance indicator. For instance, in African countries, we have an hospital in Ethiopia that focuses on patients' throughput, recovery rate, as well as cost effectiveness for the purpose of increasing their volume of patients and reducing costs. Now, the Department of Health of the South African nation uses staff to patient ratio, treatment efficiency, as well as resource utilization to improve allocation as well as service quality across public health facility. So these are important things that we are not even bringing to our fore, even to our attention while we are giving our services, which is very, very key. It's not just about going to the clinic and getting the patient and seeing him after 1 hour, he goes home, he comes back the following day and receives the same. That is not enough. If we can have monitoring and evaluation, a proper one in place, and we utilize it maximally, the difference will be obviously clear. The patient will benefit And we as experts will be proud of our services, and our employers will be proud of us, and the society at large will be happy with what we are doing. In Uganda, we have a referral hospital that monitors average length of stay, patient satisfaction, as well as functional improvement, just to ensure efficiency and effective care.
Sir, your audio is lost. Well, I don't know if I'm the only one that's here. Please, sir, we cannot hear you, sir.
Hello, sorry for the interlude, please.
No problem. Thank you, sir. We can hear you now, sir.
Actually, you know, I'm working from home, not at office because of the light issue. So actually, I forgot I locked the main gate to the entry. And somebody just came in. I had to go and open the gate for them. Yeah. So now for the service performance indicator, right? We have seen the Mulago National Referral Hospital. They monitor average length of stay, patient satisfaction, and functional improvement so that they ensure efficiency and effectiveness of their services delivery. Right? Now, this same example we have for SOTA HITS Data Aggregation Center in California, right? The SOTA Health implemented a system-wide electronic health record platform that they use to collect rehabilitation service data, which they aggregate into a central repository for analysis. This integration gives them an edge to be able to monitor their services and progress across different locations. And they were also able to identify trends, such as readmissions as a result of incomplete management sessions, right? And after analysis of this aggregated data, they introduced home follow-ups that reduced their number of readmission by about 15%. Now, again, when we come to Nigeria, we have Lagos University Teaching Hospital that monitors recovery rates, the satisfaction of their clients, as well as time to treatment initiation for the purpose of tracking patient-centered outcomes and organizational efficiency. ABU, on the other hand, they use functional improvement rates, appointment adherence, resource allocation to measure rehabilitation service performance and guide efficiency improvement. And in UI, the treatment adherence, recovery time, patient outcomes were tracked for the purpose of identifying or making sure they provided high quality service that focuses on patient experience and recovery speed. Now, when you go to the next slide, what do we have in the next slide? Applying and reporting performance measures. And we have 3 countries here as well. The Rwanda's experience, the Namibia and Zambia. For instance, in Zambia, they usually present findings on patient outcomes and cost effectiveness in their national health reports, right? You remember this is the reporting aspect. How do they do it? They use interpretations that identify service gaps and adjust national strategies on these particular areas that they have worked on. And in Namibia, they quarterly compile performance assessments using cost per patient and recovery outcome. This helped them in realigning their abundant or scarce resources across the regional centers. So based on these things, they would observe there are some places that require more resources than others. So instead of giving it, what do you call it? The principle of equality, they now use this principle of equity, right? So that they give everybody, any person what he deserves. And in Rwanda, they developed a semi-annual performance report, which look at the functional outcomes, patient satisfaction, as well as use of resources to help them track improvements and plan for their future targets. In our own case, we use the national data protection policies for, what do you call it, for guidelines, right? To ensure patient data privacy, right? Especially in public health facilities. For instance, the Lagos used that policy to anonymize patient data in research reports and using some encrypted storage for patient records. This helped them bolster patient trust and allow more comprehensive data collection without concern for infringement on clients' privacy in any case. So we have examples of reports from National Orthopedic Hospital, Enugu, Medical Center, Owerri, and University of Ilorin Teaching Hospital. That their reports focus on patient throughput, satisfaction, and recovery, and their outcome is to improve culture and address services. And this is very, very important. We need to look at the environment, the culture, and tradition of service consumers so that we can address the necessary gaps. Already their report focused on the patient recovery and resource utilization in order to optimize scheduling of their treatment as well as improvement of outcomes. In the case of University of Ilorin Teaching Hospital, their report focuses on patients' adherence, patient satisfaction, and service charges per treatment. And it helped them have a targeted therapies introduction for high need groups. I hope my network is clear. We are following, we are moving together.
We can hear you, sir.
Okay, now I'm better, right? I had some people saying they cannot hear anything. I hope it's not now. Okay, this is a long message. Hello, please, can we confirm others are following us, are with us? Because I saw a lot of chat, people saying they can't hear anything. Okay, all right. All right, now they can hear. They are following, right? Now for data collection and aggregation, in Mozambique, the Ministry of Health collects data and aggregates them, data for rehabilitation actually, by using a centralized electronic system which they partner together with WHO. And this gives them easy data sharing and reporting ability. Ghana too, their health services integrated the patient data from multi-sources into a centralized database. Their benefit is getting a real-time data access for service improvement. That means the data is centralized and so it can be accessed easily from wherever one is. For instance, in Nigeria, if we have something like that, so when you want to have information regarding particular situation, from where you are, you can just access it. All you need is to have the access code. Perhaps they will domicile the access code at various healthcare facilities where people are working. We can easily access them and make proper use of them for the purpose of improving our service delivery, whether it is access, it is satisfaction, or whatever. Now, in South Africa, the National Health Laboratory Services does the same thing, collecting data from various provinces and aggregates them into their national health reports. And this helps them to identify where there are high needs from the various provinces they must have accessed. So the same thing, we have a center in the US, they call it Kana Millennium Platform. They set it in a multi-center setting where they have a comprehensive health information system that they use across multiple hospitals to integrate rehabilitation data into the patient records And so some of what they take is looking at each of the rehabilitation session and they record them, including the goals, the session summaries, and progress reports. And this give them, with this integration, give healthcare providers across the country access to patients' full medical history, which has improved continuity of care and help avoid treatment duplication by enhancing patient outcomes in their multi-center rehabilitation programs. So for the data collection and reporting policies, there are examples of from Kenya, Rwanda, and in particular our country as well. For instance, in Kenya, they have Health Act 2017 that emphasizes data protection for sensitive health records. So usually facilities make sure they use anonymized data for the purpose of reporting. In order to comply with this, so that they avoid litigation or legal issues. And in case of Rwanda, their healthcare policies mandate that data storage data storage is secured and anonymous reporting of patient care is enhanced. So this gives better confidentiality. And sometimes this issue of confidentiality as they are very, very important for retaining patients and gaining patient trust so that you can get more information that will guide or help in your approach for proper care for the patient. In Nigeria also, we use the same NDPR guidelines so as to anonymize patient data as well as making sure there is strict access policies so that the data access and the privacy of the clients are protected and they are well complied with.
We can't hear you again, sir.
Please, sir, you're not audible anymore, sir. Prof, sir, we cannot hear you, sir. Apologies, due to the network issues at the facilitator's end, the network kicked him out and he's trying to re-log in and rejoin the meeting.
Yeah. Yeah, thank you, everybody. Sorry for the interruption. So I don't know, I think is it from here we stopped then, talking about examples, the case examples of the experiences about monitoring and evaluation across nations as well as facilities. So like I said, for instance, service delivery indicators. Our Nigeria's example, we have about 3 hospitals that tracks, one of them tracks waiting, that's the University of Orthopedic Igbobi. They track waiting time, accessibility to service, as well as the functional recovery of their clients. And when they collected the data, which is via electronic health records, they interpret them. They also add more data by a survey of a follow-up. When they found from their findings, their interpretations of the findings were used to come up with approach that helped in reduction in the waiting time. That's the patient waiting time. Instead of patient to come from 7 and received treatment around 12, he is rather given the appointment to come around that exact, maybe 11:30, quarter to 12. So by the time he came in or she came in and the records are sorted out at least in the 5-15 minutes, they can now receive their time. So you can see how monitoring evaluation will help us improve a lot of things. In this case, the stress on the, what do you call it, on the professional is reduced. And the stress on the client, which is both for the spending and for the time they will come and be wasting, which could have been used for another things, especially with their own caregivers that may be coming with them to the hospital, is all saved. And at the end, they receive the required services as expected. So in the case of a Federal Neuropsychiatric Hospital, which is also in Lagos, they use their approach via monitoring of how well clients adhere to their treatment given. They look at also the rates at which the condition relapse and the outcomes that determines or show the extent of recovery, right? So with this and regularly reviewing their data, they were able to identify some sort of approaches which give them the leeway to come up with a community-based support program, which they developed. By essence, it can help them in integrating the clients back to their community. And perhaps they will bring in the services for their clients at the community level. And as a result, it does what? It must have reduced some unnecessary costs on the clients, and then time wasting from the client, and their own efficiency as professionals. Now, in the case of University of Abuja Teaching Hospital, what they do in their own case, what they look at is their client satisfaction. They gather information regarding their client satisfaction. They also look at the accessibility of their clients to their facilities or services, right? And they also monitor and study and gather information regarding the time to recovery. That's the duration taken for clients to recover, right? So what is the outcome? Help them discover. And what do they use it for? It helped them decide on the nature of staffing and the treatment scheduling, as well as adjustments. Again, consider this another approach, so that you may not necessarily, when you come to the clinic, as you enter, you will see 20, 30 clients waiting for you. And you are very, very sure you cannot finish with them in the next 2-3 hours. That means some of them will waste their 3 hours waiting for your services. So by coming up with idea on how much and how long each client will receive, right? You can now allocate the the time for the patients. So by that, you must have reduced their waiting time. Now, service performance. It also uses various approaches and various indicators that will determine what do you want to. For instance, in this case, in Addis Ababa, the services or the hospital give its attention on the patient's throughput, right? They also look at the rate at which their clients recovers and how cost effective are their services or the service rendered by them or the service received by their clients, which is very, very key. The issue of funding is very, very important. Now, funding of healthcare services is not as easy as it used to be. We all know that now it is no more like a free healthcare services. And the insurance that take care of clients does not cover everybody. And we know those that are below poverty line are the most in population. And they are the most vulnerable in coming off with all these ailments. In fact, the common term they are called is the bottom billion. So definitely the issue of costs is very, very key to look at how effective cost-wise is our services, right? So that we can now use it to improve or increase our patients' volume. And at the same time, we reduced the cost of receiving the services from us. That is what they did in Ethiopia, and it helped them a lot. The South African Department of Health, in their own case, they look at the staff-patient ratio, right? So we can say how many physiotherapists is to the client that requires our services. Is it 1:500 or 1:3 or 1:5 or 1:10? They don't look at that, right? They also look at how efficient it is. Of course, from your client to patient ratio, you can be able to figure out how efficient the staff will deliver. If, for instance, every day when I go to clinic, I will have to treat 30 patients, 35 patients, 40 patients. Your guess is as good as mine. I may not be able to give them the best. And at what time, actually, if I should see 30, 35, 40, 50 patients in a day, how do I allocate the time, the treatment time for them? You know, so let's say we go 8 in the morning and you close 5. You may need rest, isn't it? You may need to take break. And how many time do you allocate for each of your clients? So when having all this information, it will help us to come out with where do we need more hands, or how do we even allocate the patients, and how we can even refer some to other facilities so as to reduce the burden on the staff, right? They look at also treatment efficacy, like I said earlier. If the load staff to patient ratio is not convenient, definitely the treatment efficacy will be compromised, right? And they also look at resource utilization, right? All is to improve allocation as well as service quality. Just like I said, if we can see this facility has 101 clients, so when the government comes to employ, we have to convince them. we have what it takes to convince the government or whoever that may employ for the facility, employ more hands, so that the efficiency will be there, and that one will give the patient the qualitative service they may require. And in Uganda too, right? They are national referral hospital. I think they have only one big hospital in the country. It's not a very big country. So since it is the national referral hospital, it is given the required attention and funding and taking most of the responsibility. So they monitor the average length of stay of patient. Again, just like we say, waiting time, which is very, very important. We have to look at that. And a patient satisfaction, right? And how they improve functionally, right? They use all these things to see how they improve in their efficiency and effectiveness in their care and service delivery. Why do you come back? Which we said in Nigeria, the Lagos University Teaching Hospital does virtually the same by monitoring the rate at which their clients recovers. They also assess their patient satisfaction using the whatever tool that will define the satisfaction. And then they look at even the waiting time also. That's the time to treatment. This is purposely for them to see how they can be able to identify whether their patient-centered outcomes as their approach is giving them what it is expected, and by implication affecting or showing how efficient is the organization. That's monitoring and evaluation. ABUTS uses functional improvement rates. How one improves functionally, not just about improvement, but functional improvement. And how do they adhere to the treatment appointments, right? And how resources are allocated. And this helps them to measure the rehabilitation service, how well it is performing, right? And from there, they identify where they will provide improvement in their efficiency. Like I observed also, the same thing in University College Hospital Ibadan. They track their adherence of clients, the adherence of their clients with the treatment provided. They also look at the time it takes for the client to recover. And they also look at, isn't it? And this will help them see how they can provide high qualitative service, especially giving attention on their client's experience, as well as the rate at which their clients recovers. Yeah, next is applying and reporting performance measures. So maybe when we finish with the local ones, we will go and give attention to these multinational organizations. In Rwanda, a semi-annual performance report was developed. So when we say semi-annual, it means maybe biannual, right? That reports the functional outcomes of their clients, the client's satisfaction with the services he received, and then how well the resources available were used. It helped them track improvements in their services delivery, and they used it to develop or set the future goals for the services they will deliver to their population. And in Namibia, they also look at the performance assessment, which they compile quarterly, that's 4 times in a year. They use indices such as the cost per patient, right? Meaning the cost of treatment by patient, how much is expended on a client, right? Quarterly. And they also look at the rate at which the client recovers, right? And with that, they adjust or align their resources across their regional centers. In Zambia, for instance, in their own case, their findings, they work on patients' outcomes as well as cost effectiveness also. They use it to develop their national health reports, and they presented them as such, right? And interpreting which help them to identify the service gaps and which they use to adjust their strategies. And our reports from Nigeria, we identified 4 hospitals. The National Orthopedic Hospital in Enugu focuses its report on the patient throughput, patient satisfaction, and the rate at which patients recovers. And they use this to help them have a better improvement in how they look at the culture in their approaches to management of their clients. And it also helped them address some service gaps that is identified from the information they report. Again, from Federal Medical Center Owerri, which is in Imo State, their own reports focuses on patients' recovery. That's the duration with which patients recover, or how much patients recover, or how well patients recover from their services, and how much of resources do they utilize. And as a result, it helps them optimize how they schedule their clients' therapies and improve clients' outcome from the services delivered. In University of Ilorin Teaching Hospital, they focus their report on adherence of the client. How well are their patients adhering to directives, including home programs, including proper medication, and keeping to appointments. They also look at how well the clients are satisfied and how much they charge by care, by head. And because of that, they conclusively came up with what they call targeted therapies for the group that are in higher demand. Of course, these groups are the vulnerable groups in the society, the poor and the less privileged. Now, data collection and aggregation. In Mozambique, rehabilitation data were collected and aggregated via what they call centralized electronic system, which they have partnered together with the World Health Organization. And because of this centralized electronic system, the sharing and reporting of data or information became easier in that country. Now in Ghana, their health services integrates patient data that is brought from multiple sources into the same centralized database, right? In Mozambique, they call it centralized electronic system. In Ghana, they have it as centralized database, right? Which now have real-time access to data. That means at any given point in time when you need to access data, you can easily get access to it because it is centralized from different or multiple sources. So you can get a lot of data, a very big data to use. And this one gives them leeway to improve the services given their clients. Now, the National Health Laboratory Service, that's in South Africa. In their own case, they collect their data from the provincial regions and they aggregate it into what they call their national health reports. And in this, they are able to identify the regions, because the information and the data are collected from what? From the provinces across the country. So they are able, based on this data, You know that data doesn't lie. You'll be able to identify which area have high demands or in need of more attention in terms of services provision. Now, when it comes to the policy of data collection and reporting, we have example of Kenya, Rwanda, and Nigeria. In Nigeria, we have examples of National Hospital in Abuja, the Lagos State University Teaching Hospital that strictly follow the national data policy and reporting guidelines, which specifically look at the confidentiality of clients. And so based on that, they make sure they anonymize all their clients' data. And as a result, right, it protects their clients' privacy and it ensures proper compliance, right? And this will give the clients, like I observed earlier, more confidence and trust to come out and share some vital information that will help even in our care delivery approach. Rwanda, their healthcare policies act mandate secure storage and anonymous reporting of patients' data. And this ensures there is confidentiality of the patient's information dissemination and proper alignment with the global best practices. And in Kenya, generally they follow their National Health Act of 2017. The act generally gives emphasis on protection of data for sensitive health records. So definitely the facilities had to anonymize data when they come to report in order to comply with the standards of what? The privacy policies. Now the health information system integration. This, like I said, remember all these ones are just key examples, not exhaustive of the available information around the globe. But just to give an example so that we can have the clearer picture and idea of what all these key factors that make up the monitoring and evaluation system are actually meant for. So like we said in Botswana, their own health information system integrates rehabilitation data and so allows providers to look at patient records across facilities. And as a result, it gives a better and proper coordination when it comes to patient care. Because it's a national thing. So for instance, if there is this integrated database, what happens is, for instance, if I have a client that happens to be in Maiduguri for a purpose, and he came up with a problem, and once he's seen for the time he stays in Maiduguri, by the time he is leaving his permanent about maybe let's say in Niger State, So once he gets back to Nigeria, all they need is to get the access code to his details. That's the advantages of the integrating one share. This one? Right? So this is where the advantage of the integrated database comes in. So you can easily continue from where he stopped from. So you don't have to start gathering or generating data all over. As a result of which you can see there is, what do you call it? Loss of time and other resources. Uh, why are you so okay. Yeah, so in the University of Abuja Teaching Hospital, in their own case, they include rehabilitation module into their what? Into their health information system, which is very, very good. Although we are not sure who they invited to be part of developing of rehabilitation aspect. Anyway, at least it's good it is there. All it maybe if there is need is for us to adjust it and additions and deletion and subtraction and multiplication done. But at least it is there, right? And so as a result, it helps them to have what? A seamless flow of data, right? Between various departments. And so the continuity of care may not be breached somewhere. Unlike the usual thing that they will send it to that you have a referral, you have to start collecting all over again. With this integrated data, you need to subject your area that you need it. So information already there, right? And in Ethiopia, I don't know. The Ministry of Health also includes rehabilitation data into their health information system. So as a result, it supported streamlining referral systems across various facilities and across various services and various professionals' input, right? And it will help in smooth follow-up of care, right? And improvement of care as well as continuity across facilities, like I said, because it is a national database that each and every, what do you call it, facility can access, each and every professional can access, right? Now I want us to look at the case examples of method of engaging rehabilitation service users. I have an example of Mayo Clinic here. They call it Mayo Clinic Patient Experience Program. What they do is that they make sure patient feedback is incorporated into their activities via what? Via taking surveys to look at patient satisfaction, conducting focus group interaction with patients, and then making sure they have some specific follow-up calls their patients after discharge, like I said, especially when it is for long-term outcomes, right? For example, they use a feedback from post-surgery rehabilitation patients to extend service hours, making it easier for patients to attend follow-up appointments, right? And this gave them what? An edge where they have about 20% increase in patient satisfaction scores, which reflected better alignment of the hospital services delivery with their patients' needs. So this is a case example of patient care approach, isn't it? Right? Now, how do we conduct the patient audit? We have example of the Canadian Institute for Health Information. Institute for Health Information Audit. They call it CIHI. They usually conduct their service audit across Canadian rehabilitation facilities. What do they focus on? They focus on standards compliance as well as data accuracy. So what they actually look is to look at the facilities, whether, I mean, the rehabilitation service facilities, whether they comply with the standards that are already set on ground, and how accurate are their data entries and record, right? In giving example, where they found inconsistencies in a physical therapy documentation, and they make sure that they put that facility on focus until they standardize their documentation practices, right? And so as a result, the auditing process helped them improve in their record accuracy as well as enhancement of their patient care continuity, so that compliance with national standards are not ignored. Very, very important. If there is a set standard, every facility is expected to comply with it, except that if there are some observation and anomalies somewhere with the standards, and which also will only be observed when we are generating data, analyzing them, and interpreting them, as well as reporting them to the appropriate stakeholders. That's when, if there are some, what do you call it, issues, can now be observed and what do you call it, corrected as appropriate. Now, in record keeping, we have the New Zealand's Auckland District Health Board, which uses digital record keeping that they transitioned somewhere not long ago, and it helped in having every patient's rehabilitation records that covers not only their treatment, but also their progress notes. And as a result, it enables them have instant access to records, improving efficiency, as well as reducing errors associated with manual records, right? And as a result, their staff were able to save about 15% of their time that they usually spend on administrative tasks. And as a result, what happened? It allows or provided more time for their clients' care and attention. I hope we don't have problem anywhere. Let me see chats. The chat now. Okay. There is no new chat, right? So we are all following, right? Since I cannot see no new chat with complaints. Right, the Cleveland's Clinic data visualization dashboard is an example of data collection, including their visualization, right? The clinic uses data dashboards, just the one that I gave example, that is developed somewhere in Nigeria. They are similar of that, to monitor the key performance metrics in their rehabilitation departments. For instance, they track patient recovery time. They look at discharge delays. So if there are some patients that are supposed to be discharged or they are delayed, they also look at that, and they also assess readmission rates through what? Visual reports, like I said, dashboards, right? In a real-time way. So based on that, they identified that certain discharge delays were as a result of transportation issues. You can now see, so some remote aspects of issues that will help us achieving best for our client may not be overlooked, but with all this clear-cut, detailed work, some of these things can easily be addressed, right? As a result, they have to come up with patient transport program. And with that program, they were able to reduce the average discharge duration by about 30%. Not 1%, not 5%, not 10%, not 50, not even 20, but 30%, which is a very, very big number. So who knows, if we can come up with some of these things here, we can see the need for providing patients transport programs, especially our own services. I believe you agree with me. We have a lot of patients that misses their visits because of the issue of transport, whether it is the financial aspect or the accessibility or what do you call it, the road facility aspects. Right? Now the use of what do you call it? Standardized service outcome measures. I have example of university hospitals in Birmingham where they use functional independence and movement scale, FIM. Functional independence and motor scale, I think, right? So they adopted the FIM scale for the purpose of standardizing their outcome measurement across their rehabilitation services. When they tracked the FIM scores, they were able to identify that patients at specific given age group have slower progress in mobility. Can you see the importance of the outcome? And this now prompted the introduction of 8 specific therapeutic programs. And as a result, they recorded notable increase in better recovery rates among their adult patients. Right? So now what about the imputing rehabilitation into health information system? The Singapore Health Services, they call it, they give it a synonym, Sing Health, like singing, Sing Health. They call it Singapore Health Services, Sing Health Data Input Protocols. This services established protocol for ensuring accurate and timely data entry into their health information services. How do they do it? They carry out training sessions for the staff on how to carry out their data entry according to established best practices. They now also introduced sort of a quality control audit for the information, right? This resulted in an accuracy improvement of their data. It reduces discrepancies in patient records, and it improves clinical decision-making reliability. So by this, they bring about having a very reliable clinical decision-making. Now, what about conducting surveys? In the case of conducting surveys, I have an example of John Hopkins Rehabilitation Services patient feedback surveys. So what do they do there in their rehabilitation services? They regularly conduct surveys for what? For their patients in order to gather feedback on accessibility, quality of care, as well as effectiveness of care. In this approach, they identify somewhere that their clients support after discharge. And so they introduced what they call digital post-care support system, which is a follow-up program that helps in improvement patient satisfaction scores. And it also decreased rate of admission into their facility, which shows that the impact of surveys on service enhancement are not small. So I think I can stop here and get feedback from the attendees about the workshop generally and what do they feel about monitoring and evaluation of rehabilitation services. Especially what I expect to hear is their thoughts and their experience before this workshop. And maybe now that we have had this information, what actually changes and where. So the floor, I will let the floor open, please, for contributions. Hello?
We are with you, sir. We can hear you, sir.
Okay. So please go ahead and announce them.
Okay, please, if you've got questions, contributions, comments as regards the workshop thus far, please kindly drop in the comment section or you
can raise
unmute and
your, or you
or
can
raise your
raise your
hand. Thank you.
Oh, sorry, a time is blocking my. Yes, I'm using the same system to charge my phone. So the phone, anytime I check the system, what do you call it? The code will. It's like the code is shaking, and anytime it shake, it indicates that the system you can see. So just bear with me. Anytime I'll try to be blocking it. To be closing it.
Sir, Anthony Mashara, his hand is raised. Please kindly unmute and speak.
Sir Anthony Mishara, the floor is yours, please.
Good afternoon, Prof, and good afternoon, my senior colleagues and colleagues. Please, I still want to ask Prof, with respect to question asked earlier by Samuel Buni from Madibo Adama. Yes, sir. Yes, in process of us, sometimes, I mean the physiotherapy profession, trying to get information in this regard, where we know the best information that we need and how we can be able to manage it to get maybe improve our services to our patients.
Yes.
It's difficult sometimes because in hospitals whereby you see CMDs or the chief medical directors are medical doctors, and they always want to go only the medical way, which they are conversant with. Like, for example, there's this hospital, we are trying to see, okay, let us have a physiotherapy folder for our patients that will be coming. There, in one way or slightly, our biodata for the patients that we require, we will be asking them, may differ a little from somebody who is just coming to see a medical doctor. Yes. So some of them, or in that hospital that I'm giving an example with, they are saying, no, we cannot even have a physiotherapy folder. So what I want to ask Prof is that, can't we have a legal backing or legislative backing in such a way that, okay, we can have like a protocol or our own procedure of getting information from patients? Not necessarily we have to always follow what the medical doctors always want us to do.
Okay. That's a good observation. I mean, question and concern. I don't know, when you talk about legal backing, I am not a lawyer, but I don't know how heavy it means. But what I am seeing, you don't need any legal backing. I think sometimes some of these things are personal, because you can discover in some other hospitals, these things are allowed. Isn't it? So you can agree with me, if there are some illegalities around it, some places will not allow them to be done. Right?
Yes.
And if some places allow them done, it means they are legal. So like I said, sometimes it's individual, even among the doctors. There are some individuals. Although better things are coming up with this rehabilitation agenda, actually, and we have a listening minister for health, and the board is up and doing. Some of these things will be addressed as things unfold. But what I am saying is, this soft skill is political approach, right? Sometimes it's not in every battle or in every situation that we
I'm losing the audio.
With advocacy, understand?
Yes, sir.
Things will be changing, and sometimes when the regulatory body in that area, they will be sharing some of this information. I mean, telling them the importance of some of these things, right? And sometimes we ourselves have some things to play. For instance, if we can be coming out with whatever we can call it, if it is a mini seminar, and once in a while we'll be inviting them, and we'll be discussing some of these things and referring to global best practice. Although they know, they try to pretend, demonstrate ignorance. But once they see we know what obtains globally, to some extent, they will be given up actually, or they will be given in whatever what I can use. So actually, it's not like an issue of legal battle in this case. It's about issue of ethical reasoning. So they need to reason that each healthcare service provider or each expert in the hospital, he has his own approach of addressing the concerns of their clients. And because of that, that difference must manifest somewhere. So that is what I can say. I don't know, it's open if somebody has something to add, maybe from their experience or from their own thought and so on and so forth. Please, let's make the session interactive. Let's share our ideas and thoughts. Thank you. Do we have any other person? Yes, I am seeing Usman, Abubakar, and Tawakkal too. Usman, please. Go ahead, unmute yourself. Hello, Usman. Okay, if Usman is not, or maybe his network is having problem. Tawakkal to, please go ahead.
Good afternoon,
Okay.
Prof, and good afternoon, my colleagues. I'm
Yeah.
Takaito therapist. Please, I want to find out ways of improving survey enhancement. I want you to explain further, please.
Come again. Sorry, repeat yourself clearly.
I want you to explain further the ways of improving survey enhancement.
Okay, announcement of survey. Okay. Usually surveys are sort of cross-sectional studies that want to extract information at a time, right? So why we are referring to the announcement is the way by which you can reach your, what do you call it? Your potential participants or subjects, as the case may be. So there are various ways that you do them. You have the physical way. Of course, if you want to get information from, let's say, for instance, you have your patients, you want to look at the issue of waiting time. You have come up with your design, like I said, it must have to be very, very clear. And the information is not ambiguous. You identify the problems you want to solve. When you have it, you can now meet them during their, what do you call it, at the reception before their treatment time. You can give it. This is one of it. That's physical, right? Another one is by mail. You can generally, depending again on your prospective subjects, you can gather their emails and send it to them, right? Another way is having Google Forms sort of with all your information, I mean, your questions and so on and so forth. You now send it to various platforms, right? Another one is there are applications that you use. So all these Google platforms, applications, and so on and so forth, they are basically online things, right? And there are offlines too. You can send to your specific personalities that you know. It can also be via email so that they can. This is it. Now, the important information is that before the main body of the survey that has all the questions, you have to have like an introductory part that will give clear information about the purpose and the aims and the objectives and the risk, if there are risks related to it, and the confidentiality of information and so on and so forth. And ideally, persons that are supposed to respond must consent and accept the conditions that you explain. And after that, they can fill it and take it and send them back to on the appropriate way as you may. And some of them, you can even do them on phone. You have also survey that you can make phone calls. You gather the information of your clients and you can be calling them and you are taking your information from them. I hope I've explained what you asked. Thank you.
Yes, thank you, sir. You've explained, sir. Thank you, sir.
You're welcome. Next, Usman Abubakar.
Hello, sir.
Yeah, please, the floor is
Thank you,
yours.
sir. Thank you very much, sir.
You're welcome.
Okay, sir. My own is just a contribution.
Yes, you are welcome.
In line with the previous speaker that speak about the legal backing and what have you. I think that he doesn't need anything like that. What he needs to do, because physiotherapy is an independent unit in every hospital. So the only thing that he needs to do is the standard of operations. Every unit must have submitted their standard of operation to their management. So what they need to do is to go and review that standard of operations. In the SOPs, they should write how they want to deal with their patient, how they want to see their patient, and everything. Then they will submit to the management. I think that's the right thing to do. It doesn't need any legal or something like that.
Okay. Thank you very much. That's a good point. So the next, Kabiru Mansour Olawale. Are you with us?
Yeah, good afternoon, Prof. Sir. Thanks
Good
for the
afternoon.
presentation so far, sir. My
You
name
are
is
welcome.
Kelani Monsuru.
Sorry, it's Kelani, no Kabiru. Don't mind my eyes. Thank you.
I'm an audiologist with my Tama District Hospital, Abuja.
Okay, welcome.
Yeah, in respect to the discussion so far, I just want to line out I need your input, let me put it that way, in
Okay.
regards to, because as an audiologist or speech therapist, we discover that we work interdisciplinarily with ENT surgeons.
Yeah.
And in some centers whereby you are intending gathering data for better coverage and analysis in respect to what rehabilitative is all about. And then in some instances whereby some of the surgeons discover that maybe in our own centers, we have 40% to 50% of the needed machine for diagnosis. And then once the patient is reviewed at the clinic, they felt that we don't have machine for auditory-based sense response. From there, the patient are sent out to either a private centers or other centers that has. That means that same participant has been missed out in coverage. So with these, I think these are part of challenges. I'm talking about those that has to do with lies on one professionals before the activities can be touched accurately. So in that same way, the level at which information will be gathered will be of limited in that way. Sir, now the question is, what is the better way to make sure that everybody are being captured when it has to do with coverage of information for better, so that we can be in the same shoulder length with other, even sub-Sahara or international health sector? Thank you, sir.
Thank you very much. Very good concern and observation, even question at the same time. Like I said earlier, there are a lot of issues. If it were in a similar scenario, things like that, even things that will help improve provision of resources, just like a patient or a client, wherever is referred to a particular unit or service aspect of the hospital. Unfortunately, there are these are some of the things that can populate the issue of accessibility of the clients. And now once you come up with the report, when issue of resource allocation is brought in, these are some aspects that will be given preference so that subsequently clients will be benefiting from it. But now, like you said, our issue is the nature of the supremacy or so-called of our other professional multidisciplinary members, medical doctors. Again, this one too also is something that calls for advocacy, and they call it soft skills. This soft skill is where to identify, again, all these things are individualistic. Some of these medical doctors, they are ready to see that the patient gets the best out of every one of us that are given their own hands. But others are entirely different, right? So this is that aspect. Now, the other issue that you are talking about is the issue of more and more advocacy and doggedness and proving what we have, right? That's what will bring in the issue of this multidisciplinary so that everybody will be carried along, right? And again, like I said, with the way regulatory body, the board is working now, I'm very, very sure things will be changing because I'm seeing a lot of circulars going to the hospitals, to the universities from the board. And I think it is more sensitization all these establishments that will help in improving the way we approach client services delivery. Thank you. I hope I've said enough. If somebody has more to add, he is welcome. Otherwise, I will allow the next person. I think I saw the registrar raising his hand. If he's around, please, the floor.
Yes,
Abayomi, please. Please be patient. Let's allow the registrar to. So then I will recognize you. Registrar, the floor is yours, sir. Mrs. Tolu, is he not there?
I'm checking through the list. His hand was raised before.
Okay.
The network has same out. His hand was raised. It's no longer online. Abayomi Faleye can ask the question now, please.
Hello. So it's like from your own side, the network is not good, or is it from my own side? I'm not hearing you again. This is Tolu.
I said the registrar is no longer online. Maybe the network has kicked him
No,
out.
I'm back. I'm back.
Okay,
Okay,
so
registrar is back. All right.
Okay.
So you
I
are
think there
welcome.
was someone that was supposed to speak. Abayomi Faleye. Has he spoken while I was here?
Yeah, I thought I excuse him so that you speak for, or if you want him to speak before you.
No, let him go ahead.
Okay,
I
so
think he
Chief
raised his hand
Abayomi.
before me.
Okay.
All right. Good afternoon.
Yeah, good afternoon.
Good afternoon, Prof.
Welcome.
Thank you for the information. It really means a lot. And this is more of contribution to the issue of the legal backing concerning some issues that has to do with physiotherapy practices in several hospitals. And just like the previous speaker said, this previous contributor, as a physiotherapist, we have a lot to do to air our view to other healthcare professional or healthcare provider. We have limited ourselves to some extent that makes other healthcare professionals think we don't have resources to back up our practice and what we can do to improve our practice. Let's take, for instance, in my place of work, Lautech Teaching Hospital, Ogbomoso, there was issue with our treadmill, and due to power surge. And there is a yearning for getting or repairing the treadmill, but all effort to repair the treadmill prove abortive. So there is need for us to get a new treadmill. So what do? We have to present a fact and data to show how useful the treadmill is. And that is where the personal departmental record of patients comes in. So when we work and we operate with facts and data, we can use this to push our demands and make sure they see the point, the reason behind what we ask for or what we demand. Sometimes, most of the audits we do to improve our service or services we render, if they are not backed up with data and facts, this will not be taken seriously. Like the prof said, most of these healthcare professionals knows these things, and some don't know. But even when they know, they just pretend as if they don't know. But at the point where we keep on hammering home, pushing home our point using data and statistics, and shows to every one of them that this is what is obtainable, this has worked for us, it can work better. So we can go ahead
and push this thing, and they will see that they have no choice. Even if they're not giving us 100% of what we asked for, at least they will start from a point. Like the treadmill issue, the efforts to repair the treadmill prove abortive. We had to submit a new our statistic that this treadmill is useful and it has generated a lot of results, not even results alone, and it has contributed a lot to the department financially. And because of this, they had to go and cross-check at the account section to see if the facts that we presented actually match with what they have. And to their surprise, it was something they couldn't shake off or something they couldn't ignore. They had to get another treadmill because they see how important it is for our service delivery. So we have a lot to do as physiotherapists. Sometimes we can do a kind of a mini audit and show this result to the management that, see, if we can go this length with this, then imagine what we can do or what we can achieve if we have this, if we have this, if we have this. So the issue of having your personal patient case file or record or something is also something that you can prove to them that you can use this to monitor your own service delivery, and it will be easy for you to audit your care delivery to improve on what to do and how to better patient's life. So that is what I want to add to the submission. Thank you very much.
Thank you very much. Actually, the truth is we need to be using our data. We have a lot of data in our various departments lying there. So I think it's high time we start, even we can be having just mini descriptive statistics for annual performance observation of our services. Even if for the purpose of the consumption within the department, it can help a lot. And one day it can be handy somewhere. Thank you very much. Registrar, sir, the floor is yours, please.
Thank you very much, Prof. This is wonderful. And I'm very happy that these lectures are going on from many different areas of the health system, because the understanding of the health system and all its components is what is going to help us to move from the level of talking practitioners and hospitals treating patients to getting the national recognition through a focusing on many various areas like this. If you look at the Rehabilitation 330 agenda, you'll see out of the 10 action points, this issue of information system is one of the two data. Whenever we attend ministry program, a retreat of the ministry and many other programs, I always see the director of health planning, research and statistics presenting the statistics, health statistics of the country. And I've never seen data on rehabilitation. So I started to find out how they collect this data, and they're able to analyze it and present it at every Ministry of Health meeting. So I realized that it starts from the bottom up. There are policies. All those regulations and laws that we're talking about, they are there. They exist in the ministry. But how do they get the data? At the local levels, let's assume a hospital, the head of unit collect the staff already, see patients. Data is collected. Head of unit forward, which is the department, head of department now sends it to the hospital. This is now sent to the Federal Ministry of Health. That was even before EMS was there. Now, from generally data from the country, you have at primary healthcare level or even at community level, someone is responsible for collecting that data. But the local government has a health officer that is responsible for coordinating all data that comes, and then they now push it to the state health officer. And then from there, it goes to the Ministry of Health. But now with EMS, it's even easier that a staff will generate the data, use the EMS to capture the data, and then this now is captured directly, goes up to the ministry and to capture, analyze through all those processes that Prof have mentioned. So I've already reached out to the directors of planning, research, and statistics at the ministry. They are willing to support us, to educate us, to guide us on how we can come. Because a medical doctor is not going to collect data on rehabilitation. And no, it's not going to go to the audiology department or ENT department to ask an audiologist to give them data, or go to physiotherapy department and ask the data to be given, and then they now forward it until it gets to the ministry. It's not going to happen that way. And the same way, they are not going to now use that data to do analysis and help in developing policies within the data. We are the ones that will do it, but we have not done it before. But it's not late. Now that we are getting educated on how why it's useful, and also how we also get involved in generating the data, passing it across to where it's important, making use of it in policies. Let's continue to go on this route. So I've also discussed with the head register of the regulatory body of the head report. What we are planning to do now is to have training for medical rehabilitation professionals in Nigeria. That's in collaboration with the Planning, Research and Statistics of the Ministry of Health and the Health Report, and then the Medical Rehabilitation Therapists Board. So, please, from what you have digested, if you can be able to come up with a template, a template or a plan for the training, let's look at it so that we'll now meet with these other stakeholders, and then we'll plan how we can have the training. And after that, we from the board can now begin to follow up either with advocacy at the lower level or also advocacy at the higher level to make sure that there is a very strong coordination to make sure that this data from the point of generating it until the point of using it for policies, that there is harmony. The Rehabilitation Technical Working Group is also expected to do that. But because they are going to have a job that is going to be within about a year, then the assessment of the board will help in making sure that this extends even the life of the Rehabilitation Technical Working Group. And if we are lucky, by the time the Rehabilitation Technical Working Group completes its exercise activity, and the ministry now establishes a unit for rehabilitation in the ministry, then we'll now have a focal platform where all these activities will be coordinated and we'll be able to create the fruit of all these things. Thank you so much for answering.
Professor Damo, please, sir, you can kindly unmute, sir.
I was mute, sorry. Thank you, Registrar, for this robust information. In fact, I would say you have summarized the presentation and even concluded it. All we need is to close with prayers now. I'm happy to, from what he has said, especially those that raised concern, you can see, I said the board is doing a lot. But we at our own level too, we have to come up, stand up and buckle our belts and get ready and be, what do you call it, up and doing. Because these data, like I said, we have a lot of data lying fallow in our various departments. So if we can be having small things, like I said earlier, that even if it's for our own personal purpose, departmental or internal consumption, one day it will be useful where we never expect. And now you can see the example now. The board have started interfacing with the national, health and statistics director. So before you know, sometimes they will, from nowhere, they will ask us to start submitting this information. So if we have some handy, and in our archives, all we need is to dust the archive and come and forward them for onward delivery. Stage, what I expected to give from 10 to 4, if I am permitted.
Lisa, were you trying to communicate with me? Because I think your voice wasn't too clear.
Yeah, I say it, If there are more comments and discussion or any observations and concerns, we still listen. Otherwise, I think we have had a long day. Maybe this is where we stop for the
Okay, sir.
workshop. Yeah.
So the floor is still open for comments, contributions, questions.
Yes. So I think, Tolu, if in the next 3 minutes no reaction from anybody, I think we are all satisfied. Maybe we check even the chats. Okay,
I've checked through the chat, sir. Nothing yet, sir.
Okay. Okay, there are no questions there. Okay. So we can close it and thank everybody. Or we can thank everybody and call it a day, right? This is so much I can give for.
I think it's all thank you from everybody.
Yes, I can see.
I think we can say the meeting can be ended since we've got no questions.
Yeah.
No further questions, no questions, no further questions, no further questions.
About that, the one you talked about.
Are you part of us or you have a question?
Mm-hmm.
Okay, I think that was done in error. Okay, in the absence of no further questions or contributions, I think we can call it a day. Thank you all for your time. And thank you, Prof. Sir, for the workshop. Thank you very much, sir.
You're welcome. Yeah, thank you. Let me post this. Thank you very much.
Thank you so much, sir.
Yes, bye-bye.
Thank you very much, sir. Thank you.
Yeah, you're welcome. Thank you.
I'm glad that you said that.
Thank you, sir.
Just
You're welcome.
How did you move on? Okay.
So, bye-bye, everybody. Bye.